I'd like to, it's a pleasure to be here. I'd really thank the organizers for having me. So I really have no relationships to disclose. I think that may be important in a talk such as this. I actually never had relationships in this field. I come neither to bury rotodynamic pumps nor to praise them. I'm hoping to give you the data and the pathophysiologic rationale and let you draw your own conclusions. That is not quite the same thing as saying that I have no relationships whatsoever. So here are percutaneous mechanical support devices. By virtue of the change in schedule, we've now heard about intra-aortic balloon pumps and VA ECMO, and in between you have the axial flow pump, the Impella, and the centrifugal flow the extracorporeal pump, the TandemHeart. And you've also had a chance to see pressure volume loops earlier in the day, and here's a normal pressure volume loop. You can see end systolic elastance as a measure of contractility, and an arterial elastance as a measure of afterload. And here's a normal pressure volume loop. And when your heart begins to fail, your contractility goes down. Maybe your afterload changes a little bit, but your pressure goes down a little bit. Your stroke volume goes down a little bit, and we'll call that something along the lines of compensated heart failure. But when you get into the cardiogenic shock, the contractility goes down, and now you're in big trouble. Your pressure is low, your stroke volume is low, and you're really looking for some sort of support or a reversal of the underlying condition. And I also want to talk a little bit about myocardial oxygen consumption, and to remind you that this is the area under the combination of two curves, the curve of stroke work and also the curve of potential energy. So remember, your heart doesn't fill to total empty, so there's a potential energy in order to get to that initial volume, and the area inside this entire curve equals myocardial oxygen consumption. We'll talk about what the rotodynamic pumps do. Here's the TandemHeart. I'm coming from Hackensack to Houston to talk about the TandemHeart. Maybe I should have brought my coal, and this is Newcastle. But in any case, this is the TandemHeart. It goes across the interventricular. It's a continuous flow device. It's a septal puncture. It takes oxygenated blood out of the left atrium, and it pumps it back through the femoral artery into the heart, and thus does partial work of the heart. And then you have the Impella. This is a continuous axial flow pump, and it is a little easier for your average interventional cardiologist to put it in because they're already used to crossing the aortic valve with a wire. So you put this thing in, and it starts spinning and takes the blood out of the left ventricular cavity, and it pumps it back out into the aorta. There are a number of flavors of this. We started with the 2.5. And then we went up to the CP, which is just a little bit bigger but has more cardiac output. I've taken out the 5 because I'm not so sure. Now that the 5.5 is here, nobody's going to put the 5 in. It does differ for those of you who haven't quite started putting them in. The 5.5 doesn't have a pigtail. The 5 has a pigtail, and then there's an LD that is centrally inserted. As mentioned, these are a little pricey, somewhere around $25,000 or $30,000, depending on how your hospital negotiates. And it does all these good things. It takes the blood out of the heart. It decreases inflow, it decreases end diastolic volume and end diastolic pressure, and thus decreases myocardial oxygen demand. And it increases outflow, it increases aortic pressure, it increases flow, it increases cardiac output. So when you go to the pressure volume loops with either of these two percutaneous devices, what you see is that, yeah, that sort of works. What you see is you go from here and this myocardial oxygen consumption to down here, because remember, the machine is doing the work, and it's using the electricity from the wall socket as opposed to myocardial oxygen consumption. So this provides anywhere between 2.5 and maybe even a little more than 5 liters of cardiac output. It decreases the afterload of the heart somewhat, and it decreases the myocardial oxygen consumption, sort of both the things that you'd like to do if you wanted to support your heart. So this really addresses the pathophysiology of cardiogenic shock. This is a color version of the little diagram we put together 20 years ago. And Holger Thiele actually made this graph, took the studies of the pumps, and he looked at what they do. So they do all the things you'd want to do in addressing the pathophysiology of cardiogenic shock. They increase cardiac index. They decrease pulmonary capillary wedge pressure. They increase mean arterial pressure and address the hypotension. And actually, if you look at lactate as some measure of systemic perfusion, the lactates go down. So the pathophysiology of cardiogenic shock is addressed. This is great. So, do they work? Well, first of all, there are potential complications. And here they are. They can get infected. There's a thromboembolic risk. If this catheter is sitting in the left atrium, that thromboembolic risk can go to really bad places. There is potential bleeding with all these catheters. They can fail. There's the potential for multiple organ system failure. The Impella is spinning these red blood cells really fast. They start, your platelets get chewed up, and there's hemolysis, and you get all the potential trouble. So you actually can get in trouble with these complications. And as you might figure, the longer you leave them in, the larger the incidence of complications is. So where are the data? Well, there are observational data. These are data from Bill O'Neill's publication looking at the Detroit Cardiogenic Shock Initiative, and it shows improved cardiac power output, as you would hope. That's a good thing over here. It's actually the outcome, the survival is better. If you look down on the lower left, this is actually survival by volume of institution. It goes up a little bit as you get better at, put in more of these and get better at it, and maybe even get better at timing, but the survival is good. And as you've seen before, factors that are associated with improved survival are hemodynamic monitoring, and in this context, I should have mentioned that these are Impellas placed in the setting of acute myocardial ischemia and myocardial infarction, that if you put them in before you do your angioplasty, things are better. And these data are paralleled with other data looking at outcomes with early initiation of mechanical circulatory support. So on this slide, the lovely blue color is pre-PCI, and the kind of pretty green color is post-PCI. Here's the Detroit Cardiogenic Shock Initiative, and here is the US Pella Registry and the CVAD, various studies in Göttingen. And all those data suggest that if you support the heart, if you unload the heart before you start doing PCI, and that's Naveen Kapoor's trial ongoing, door to unload trial, which we won't talk about, that things are better. Certainly the outcomes are better. So this is looking good, right? All these observational studies. However, and how about TandemHeart? A little less observational data, but the observational data comes from here, including at least one person sitting to my left. And it looks over here, these data are 2011, wrong year, 20 years off. You're not that old. 2011. Overall survival about 50%, and on the right you can see survival by indication. Bridge to recovery did pretty well. Bridge to LVAD did reasonably well. Bridge to transplantation not so well. Probably because those patients were sicker to begin with. How about randomized controlled trials? Here's where things begin to fall apart a little bit. So here are the data from the available randomized trials. All of them are small. Again, we got somebody on the dais who did one of these trials. But none of the data really show anything. The latest data was the US Pella trial, and that trial there was a lot of cardiac arrest prior to the trial, which may have skewed the results. And down on the bottom, there's an analysis by Dr. Schraga, whose pictures you saw just in the first thing. And he looked at, this is an interesting analysis. They looked at patients who were randomized in the IABP Shock 2 trial, and they did propensity matching with people in the large Impella registry. So at least to some extent, those patients were matched for various characteristics. And what you see, though it's not a randomized trial, but it's a propensity match analysis, and it didn't look any different. And then, just a couple of weeks ago, came this analysis from the NCDR database from 2015 to 2017. And they took all these patients, and again, they did propensity matching pairs, and they looked at propensity matched pairs who got balloon pumps and Impellas. And this time, they went the other way. And so I'm not so sure this shows that the balloon pump is necessarily better, but it doesn't show that the Impella is better. And in fact, over here, the balloon pump had better outcomes in terms of complications and even in terms of mortality in this admittedly retrospective data with some sort of propensity matching to the degree that you believe in propensity matching. So what to make of this, in particular, what to make of this trial? I think, as we know, we're talking about patient selection, but I think this is a really good way to look at it. And it's a way that Holger Thiele, I've stolen this concept and made it slightly different colors. It's looked at cardiogenic shock in acute coronary syndromes. And it looked at revascularization. So you saw the shock trial data. So the shock trial mortality in the revascularization arm is 47%. That means that 50 to 55% of patients are going to survive no matter what. So those patients are over here on the left. And then you have somewhere around 40 to 50% non-survivors. And those break down into 3 cohorts. So you have cohort A. So cohort A are people who are going to survive no matter what you do. And then you have cohort C. Those are people who aren't going to do well no matter what you do. Those patients are not informative with respect to a device or any therapy for that matter. It's not going to make a difference, at least if what you're looking at is mortality. What is informative is cohort B. So you've got cohort B in the green, you've got the patients who used to be non-survivors, but because you do mechanical circulatory support, you save their lives. You turn them into survivors. And then you have the ones in red. They were survivors, but you got in trouble putting your device in. And all of a sudden, they wound up being non-survivors for various reasons. So this is the cohort that you want to study. This is the cohort that you want to identify. Maybe sky stages are a way to do this, but this is what we really need to do to get a reasonable test and a good controlled trial. However, if you think about this and you refract this through observational studies, if you have an observational study and you take people in cohort B who belong here, the ones who are informative about your device, and you add people in cohort A who are going to survive no matter what, your results are going to look better than they otherwise would look. Conversely, if you take cohort B, the ones you should test, and you take people from cohort C, you wait too long, you put them in just as a desperation Hail Mary pass, then your results are going to look worse than they might otherwise. And so I think it's difficult to interpret these retrospective studies and try to figure out what cohort they're in because they're so heterogeneous and you just can't figure out who the patients were in the absence of a reasonable predefined definition. That's a challenge for the field as a whole, and it's a challenge we're going to need to address until we make progress. And there is the trial, the DANGER trial. So, and you've heard a little bit about this. The Danish started this trial. They had trouble recruiting. They recruited the Germans, and all of a sudden they wound up with a really good name for this trial. And so this is 360 patients with myocardial infarction and cardiogenic shock to be randomized to open label. It's hard to do a closed label trial, right? A blinded trial. So open label, guideline directed therapy. They're looking at 360. They had 100 patients as of June. Patients with comatose after out-of-hospital cardiac arrest were excluded. And the primary endpoint is all-cause mortality at 6 months. I don't have time to go into this, but there's a protocol for escalation in both the initial Impella arm and in the other control arm. So, key points. The devices are getting smaller, they're getting simpler, and they're getting more reliable. This is shifting sands. Patient selection and timing of insertion are the key to success. You want to match the device to the indication and also to the physiology and pathophysiology of your patient. And regardless of what you're doing, you want to make sure you have a plan about where you're intending to go. And finally, last words. Thank you very much.
Now that everyone had time to absorb the truth here. That was really great, Stephen. Very balanced, and thank you for that. Are there any comments from the panel? I would start just one comment. You know, there have been these 2 retrospective meta-analyses from administrative databases that have shaken the world of MCS. Yeah. And I just think that and they have said that they've done either propensity matching or propensity adjustment, depending on which paper you look at. I think that the parameters that are available in administrative databases do not allow for proper propensity analysis, and also the scores, the generation of these scores is also retrospective. So I think that these analyses, these papers have certainly put everyone on alert that we need to look further, but I would certainly not take them as definitive evidence. And we really do need, some of the authors have said, well, we accomplished what we want, that people know we have to do a randomized trial. Well, we already knew we had to do a randomized trial. And danger shock is ongoing. And the results of that study will be available before any new study, I believe, that we can design here in the U.S. Will be initiated.
And does anybody know where they are with enrolling? Do we know?
Danger?
160. So June 18th, the 100th, June 2018. Oh yeah, it's been slow. It's been hard.
They're putting it before revascularization or after?
Yes, before.
Before.
Yeah.
I think we'll separate the indication from the device. I think obviously the STEMI population, the reason you survived is a number of variables that go into it that are independent of the device. I think it's very clear, I think, to most people in this room that these newer devices provide outstanding support and can bridge people with dysfunction for long periods of time, and we are allowing people we're making decisions, and people are surviving because of these devices. I think the hardest area to prove this is in acute myocardial infarction because the exit strategies are few. People present late. This mythical thing that, we revascularize myocardium, it then perks up, and then the patient walks out, is a very small proportion of patients. We are extremely nervous about putting in durable VADs or things in this population. The number of people who get that are small. I think where the key is if you need support, there's no doubt these devices work, and I think that's what even those, you show no difference in the meta-analyses, but the wedge pressure, the cardiac output, so the devices do what they have to do. There is no doubt about it. It's like an ICD going off and the VFib going away. You still need a randomized clinical trial to show that ICD saves lives, but there's no doubt that the ICD, when it shocks, gets you sinus rhythm, and that's a good thing.
Yep.
Yeah.
The question is, when do you put it in and in what population? And I think every time you have an opportunity where myocardial recovery is likely, you should be putting this device in, because you know that you can get across the ocean to safer waters. And so it's allowing you to be under the storm and fight till you get there. But I think in the absence of having that exit strategy where there is no device that's going to return you back to a normal state of life, then I think no matter what device we put will be clouded by being in that C category. And I think that's where we are in the field.
I think one of the things that we're learning about Impella is that while clearly Detroit and the National Shock Initiative are laying the groundwork for best practices, that's still not seen around the rest of the country. I think the paper that was put out from the NIS last year that showed that even at the highest quartile MCS centers, a right heart cath was used less than 6% of the time. And so in these patients, a right heart cath is critically important to help guide them in the weaning or escalation phase. I think also vascular access. I think having best practices, ultrasound, micropuncture technique, assessing for limb perfusion, putting a distal perfusion catheter, these are the things that if it's done in places where they're not doing a lot of them, or using these quote unquote best practices, that's where the complications arise. And so these devices clearly work, they provide the hemodynamic benefit, but it should be done in adjunct, in conjunction with these best practices that are not always implemented around the country.
If I could just add that the practical problem at the bedside, regardless of what device, is information. You don't know. And that's why the group is helpful, but still sometimes you don't know. You have to make life and death decisions based on small things, and try and decide exit strategies is the hardest thing to decide. And we all cling to the anecdotes. You remember the one that did okay. You talk to the people in Minneapolis, they'll tell you, well, 1 hour of CPR, and here's this nice pretty picture of the lady celebrating Halloween. But, we don't really know. So that no trial can really get around the fact that sometimes you just don't know what the exit strategy is, and it's a judgment call. And you can't sleep over the night on the ones that you didn't support.
I think that's a good point. All the trials, wherever we have seen benefit, two things are very clear. That these devices are support devices which provide a platform for you to do something to recover. The devices on their own will not save anybody. So you have to be able to do something to recover. Now that recovery, is it spontaneous after a myocarditis, or it is after an MI after revascularization, or it's a valvular rupture after surgical repair, whatever it be. If that recovers you, then it will benefit. and I think it's to his graph, that's what we have to identify, the cohort B. Because the moment we mix cohort A and cohort C with cohort B, we'll never be able to show a benefit. And the trick in all this is to identify the cohort B and the both groups, because if you put it too early because you get enthusiastic, then it'll be a law of diminishing returns because you will start having complications of the device when you didn't have to put it. On the other hand, if there was clear-cut recovery, now who could argue that if you have a post-MI VSD, mortality is 90% any data you show. If you put this device, keep the organs going, patient's mentation is fine, he's fine, and 7 days later the surgeon goes and repairs that VSD, the patient would survive. Otherwise, he would have not survived. But in no trial, you can pick and choose like that and show that there is a benefit. And trick as a community for us is to identify that cohort B as well as we could, and then have a very rigorous trial. I think you saw what Greg Stone and all did with the co-op trial. It was not an easy trial to enroll. It'll never be replicated. But they stuck to it. And because of that, we have such pure and good data, which I don't think will be possible to replicate ever.
You got a
basically-
comment on
And
that.
again, it's the same thing with danger, which is a very well-defined population, hard to enroll, but will give us an answer.
Yeah, I just want to comment on danger, and I think there's a lot of room for you guys to still do other studies and RCTs focusing on mortality. And I just want to make my point. We just trying to publish that actually. We looked in our Hamburg shock cohort from 1,000 patients and applied in an exclusion criteria from all the various shock trials. And for danger shock, it was 5% of the population we could have included in the trial. So this data just speaks for 5% of the shock patients we see, and it will be very similar in your institutions. So there's a lot of rooms for trials, and we need more trials. And we as Europeans actually don't understand that you guys don't go for it. I really don't see that, or not hard enough then.
No, but the reason is because the rules for informed consent are different here than they are in Europe. So it is very difficult to do clinical trials here in cardiogenic shock. Now, having said that, there have been studies in the past, 20 years ago, sorry, and there will be another study here. But it is very difficult to get informed consent because we don't have the same mechanisms that you have, which is kind of a retrospective informed consent.
Just in the last 10 seconds, just to touch your point, clinical equipoise is very easy for physicians to define, but it's very hard to translate it to a patient. If somebody's father is dying on a balloon pump and you say, I have a trial, there's a 50% chance this device may save you, but there's a 50% chance if you do a one-to-one randomization, we'll keep doing what we are doing to see whether he survives or not. He's going to turn around and ask you, you just told me my father's dying on a balloon pump and you're doing a trial where 50% chance that you'll enroll him in the same group? It is impossible to do that. In fact, this really happened in the TandemHeart. And that's the technical difficulties of keeping clinical equipoise here than in Europe.
Yeah, I see, just to comment on that, I see your point, but I personally still believe that we need the RCTs. We have Euroshock, we have ECLS shock, 2 studies for ECMO, and very, very similar to IRBP shock too. We have danger, and I completely see your point, but to go further, we need to have that. And I think oncologists are doing a better job in that.
We're mainly counting on you.
In fact, FDA has allowed, we are talking to FDA now, they are allowing us probably for the first time to do a cardiogenic shock trial where we would do propensity matching with your European cohort, because you can do that randomization which we cannot.